Dr. David Bluemke, editor of the Journal of Radiology, and I'm here today with Alexander Kosmala from University Hochburg in Würzburg, Germany. Did I pronounce that right? Würzburg?
Yes, Würzburg.
Würzburg, okay, great. And we're going to be discussing his paper that's going to be appearing in the January issue of Radiology, Multiple Myeloma and Dual Energy CT, Diagnostic Accuracy of Virtual Non-Calcium Technique for Detection of Bone Marrow Infiltration of the Spine and Pelvis. So this was a very interesting paper, and we're going to go through a couple steps and have you explain it to us today. So,
yes.
First, as we start here, could you first tell us what was the motivation to do this paper? Why did you choose this topic, and how did you come to eventually study multiple myeloma?
We had our first experiences with bone marrow imaging and dual energy CT with traumatic bone marrow changes. And then we also saw that every patient with a multiple myeloma or with suspected multiple myeloma sooner or later will need to have an assessment of the bone status. And this is routinely done by whole body computed tomography. So this computed tomography is in the exoskeleton only able to detect osteolytic changes.
So let me ask you a question. Yes. You started applying this technique to traumatic bone lesions.
Yes.
And that would seem to be a harder problem than tumor, perhaps. How do you compare the challenge of using dual energy CT for trauma with edema detection versus what you were trying to achieve with tumor detection?
Yes. So in theory, tumor detection should be even easier than the detection of traumatic bone marrow edema.
Why do you say that?
Because edema should have attenuation of around 0 Hounsfield units.
Okay, around water, is it? Okay.
Around water, yes.
You're trying to find that, okay.
So whereas malignant infiltration of the bone marrow has potentially much higher attenuation numbers.
Okay, so you have a
water.
cellular infiltrate in the marrow that
Right.
you're trying to detect with metastatic disease. And you mentioned also the use of CT. Some sites are using MRI for evaluation of bone marrow, especially in multiple myeloma, but also CTs coming first in your institution because you're doing body evaluation? Or?
Yes, CT. I think in most institutions, CT comes first. It's more available. It's faster, and it doesn't take so much time, and there are not so many contraindications compared to whole body MRI.
Okay.
MRI certainly has a place for specific patients groups. Mm-hmm. For example, patients with an asymptomatic myeloma, it has been shown that the detection of bone marrow infiltration, the number and the size of bone marrow lesions have certain prognostic and therapeutic consequences. So MRI certainly has a place and a role, but commonly I think whole body computed tomography is used.
So the idea from the start was if you can do the body screening with CT and improve the quality of the CT, in some cases the MRI may not be necessary. Is that the idea?
That was the basic idea.
Okay.
We thought to add the pros of MRI to be able to detect even non-osteolytic lesions to the standard CT, which up till now in the exoskeleton can detect only osteolytic lesions.
Okay, that's a good point, because CT, we're looking for lytic lesions in the spine and the bone marrow. There's no trabeculation, but in other areas of the spine, the trabeculation is preserved, and there's marrow infiltration. MRI currently does a better job at that, and we're assessing the new technology. So, okay.
Right.
All right, good. Well, so if you were to summarize the primary purpose of the study then, was to evaluate dual energy CT for this purpose?
Yes, the diagnostic performance of dual energy CT for the detection of bone marrow infiltration.
Okay, good. So tell us how you designed the study and what methods you took to assess that purpose.
So we consecutively evaluated patients that were referred to us for a standard routine staging for computed tomography. We used our dual energy exam for them, and then we tried to acquire them for the MRI scan.
Okay.
We took great care that there is no time between MRI and CT scan, so that no anti-myeloma treatment is delivered in between.
Okay. And you chose patients with multiple myeloma just to be specific about the diagnosis, or you had a lot of those patients coming to CT anyway? Is that the reason?
So they got referred to us from the internal medicine department with the diagnosis or with the suspected diagnosis of multiple myeloma. There were 28 follow-ups, I think, and 6 primary diagnoses.
Okay. So the idea is to look at essentially the performance or accuracy of dual energy CT, and your standard of reference was an MRI?
That was MRI, right.
Okay. So everybody had both exams?
Yes.
What was the time difference between the 2 exams? Was it pretty close?
In most patients, we tried to do it on the same day.
Oh, okay.
So in most patients, we managed to do this, but some patients, they were not inpatients, but they came back. And in some cases, I think the biggest delta was around 60 days.
Okay. So in order to use dual energy CT to detect bone marrow infiltration by myeloma, what sort of techniques did you use with dual energy CT? How did you do it?
So, well, in order to the contrast of computed tomography images results from differences in photon attenuation, mainly based on the photoelectric effect. So I think the attenuation of a given tissue depends on the one hand on the material of which it consists, and on the other hand of the photon energies you use to examine it with.
Okay.
So if you have a given photon energy, for example, created by a tube of 120 kV, and you examine different materials, then you get different attenuation values. But if you have a constant specific material and use different photon energies, then you also receive a set of different attenuation values. And this is characteristic for different materials.
Okay. So what energies did you use for the dual energy CT scanner? What energy levels did you use?
We chose the 90 kV for the low kV tube and 150 kV with a tin filter for the high kV tube.
Okay, a tin filter. And what's the purpose of that tin filter?
The tin filter hardens the high kV spectrum, so it filters the low energy parts of the spectrum, and thus creates a better spectral separation between the low kV tube and the high kV tube.
So you have a more pure high energy versus the low energy, because there's still overlap between those. Okay.
But it minimizes the overlap.
Okay. So you have 2 energies, and those photons are going to go through different materials. They're going to go through fat in normal marrow, primarily fat.
Yes.
And then if you have tumor, you're looking for multiple myeloma, those photons are going to be going through tumor. And so what are you expecting if there's 2 energies and perhaps you're take the high energy versus the low energy, the photons are going through tumor tissue, you're going to have different Hounsfield units measurements, right?
Right.
Okay. And how different are those energies at, let's say, the 90 and the 150? Are the Hounsfield units similar, or do they start to get quite different for those?
So what we didn't measure in the 90 kV and in the 150 kV data sets, but what we received were Hounsfield measurements that were already from the virtual non-calcium data set.
Okay, so the Hounsfield units, let's say one type of tissue, if it were all fat, the 90 kV is a little higher Hounsfield units than the 150 kV. But I believe that at the 150 high energy, there's a larger difference for the tumor tissue, right?
Yes,
the myeloma.
Yes.
Okay, so there's a broader differentiation between the 90 kV, which represents its signature, and a dual energy scan. Okay, so also a unique aspect of this paper and new innovation is 3 material separation, right? Could you tell us a little bit about that? Because you had to separate calcium, fat, which is benign tissue, and then tumor tissue, which is
Yes.
higher density.
Yes, right. So there is this three-material decomposition algorithm. It has been used before, and it differentiates, as you said, calcium, fat, and red marrow or soft tissue or tumorous tissue, which are assigned specific attenuation numbers, and then those materials can be quantified and consequently virtually removed.
Okay. So as you're going into it, you realize then already, I suppose, the fat Hounsfield unit's probably relatively specific for fat.
Yes.
Okay, but what about the tumor? The tumor, we know soft tissues are soft tissues. Some overlap with other tissues, perhaps you have to understand going in. Maybe other types of red marrow might overlap?
Yes, this was the tumor Hounsfield units were non-specific, so it wasn't. It was not obviously tumor, but it was elevated when you compare it to the normal background of healthy fatty bone marrow.
Right.
That you would expect in those populations.
So we have this understanding that fat, you're going to get a signal that's pretty characteristic, and then you're going to get another signal, and you still have to make an interpretation of whether that signal you're getting is actually tumor, or maybe there's different patterns that might be. You want to make sure it's not hematopoietic marrow or edema, perhaps, something like that.
Yes, yes, yes.
Okay.
So.
Okay, good. So those are the methods. Tell us about the main results of the study. How well did it work?
It worked actually quite well. We did a two-step analysis. The first part of the analysis was the visual analysis. So we just looked at the patient-based results, whether we could classify a patient as having bone marrow infiltration or not.
Okay.
And compared to standard CT, in 5 cases we were able to detect bone marrow infiltration that was not visible on standard CT. So I think this was one of the most important results.
Okay, so it just helped you with the basic CT, and that alone might be a win, I think, right?
Yes.
Okay.
Yes.
And so you did visual analysis. You found some patients, you mentioned 5 patients, that worked better than conventional CT. And that was 5 out of about how many patients?
5 out of, I think, 23 patients that had infiltration.
Okay, so that's a good percentage. That may be helpful in those patients. So in addition to looking at a per patient analysis, you also measured a lot of regions of interest.
Yes, yes.
And what was the purpose of that?
We wanted to show that not only in visual analysis and on a per patient base, but also on a per lesion base. And with a quantitative approach, it's possible to differentiate healthy marrow from infiltrated marrow. So we measured, guided by MRI, we measured the attenuation numbers of lesions and of control regions.
Okay, so MRI is your reference, and you say this area is really normal by MRI.
Yes.
What are the Hounsfield unit measurements, or what are the signals that we're getting, and how do they compare? That also gives you a lot more data, potentially, some overlap, but you get a lot more data points, so you get a little bit better statistics that way, I suppose.
Yes.
Yeah. So then you have, was it almost hundreds of data points with regions of interest?
We had 245 regions of interest.
Lots of areas, normal versus abnormal. And how did the quantitative results turn out compared to the visual results? What were the quantitative results?
The numbers were actually quite similar.
Okay.
So when it comes to diagnostic performance, we had sensitivities and specificities a little bit above 90%. So it was comparable.
Okay. So that sensitivity and specificities, I noticed they were pretty consistent. Sometimes some of our tests are very highly sensitive, but have a low specificity, or vice versa. It's kind of helpful that we're not overcalling or undercalling in that sense. So that was pretty encouraging and almost kind of reassuring that the quantitative numbers corresponded to the visual assessment of the per patient analysis, right? So that was really quite nice. Okay. And any other results that came to mind? How did the images look? How did you like the image quality as a radiologist?
The images, so you don't only get the 90 kV image and the 150 kV image, but a third data set of 120 kV like images is created. And those look in my opinion, comparable to what you're used to.
Okay.
So,
And to detect the tumor, the myeloma, let's say, in the infiltrated marrow, you were using a virtual non-calcium
Right.
image. I
Right.
think we're mostly familiar with the virtual non-contrast iodine image. So how does that differ, the virtual non-calcium? How do you do that, or what is that image?
So it basically all comes back to the three-material decomposition algorithm that is used to quantify, in our case, calcium. And if you can quantify it, then you can also virtually subtract it from the image information.
Okay, so if I understand correctly, you create the calcium map and you subtract it out of the
Right.
other material, leaving, let's say, the fat and the water image primarily without
Fat
calcium.
and the soft tissue
The
or
soft
red
tissue
marrow
image.
image. Yes.
Okay. And that was a color overlay then where you are looking at that. And I looked at some of the images. The viewers can look at the images in the manuscript, and you color-coded the images. It seemed like there's a lot of variation in the color maps. What's your assessment as a radiologist? Because it seemed like the variation would be hard to interpret. You have to look at a lot of those?
Yes. I think, in my opinion, it's not. In some cases, it is self-explanatory, but sometimes you really have to look at the dual energy overlay at the CT image and really think whether it is a artifact or whether this can be real.
Okay. So there's still some interpretation involved,
Yes.
but it's potentially an interpretative tool to help you with that diagnosis of marrow abnormalities.
Exactly.
So, okay, got it. Okay, so you've done the study, you have sensitivity and specificity in a smaller study right now, preliminary study of a little over 30 patients. What would you say are the potential limitations that with the technique? Where you had a couple of false positives and a false negative. What happens in those cases?
Yes, I think the false negatives are, those were patients that had very small lesions on the MRI imaging, around 6 or 7 millimeters, solitary lesions. And the first problem is to actually see them on the dual energy CT images. And the second step is to, if you see them, then you really have to think whether this is real, whether this can be a solitary tiny lesion, or whether this is just an artifact. And I think at this first stage we were not confident enough to call it a solitary 5 millimeter lesion, and just didn't really count this patient as infiltrated.
Okay.
So this is how I would explain the false negatives. The false positives, on the other hand, I think they are mainly caused because the elevation in attenuation numbers is not specific to multiple myeloma. It can happen due to degenerative cases, causes, or hemangiomas, or small noduli. So it's not specific. And I think this is how you can explain the false positives. Some patients showed artifacts, and one patient even, the artifacts looked like focal infiltration. So both me and the other reader, we both classified the same patient as positively infiltrated, and he was not.
Okay. So one or two other questions then, just on your results and how this may work. You looked at the spine and the pelvis. Does the technique work better in one area or another? Is it quite similar in either area? Any difference there?
Yes. It's important that there is lots of a background of healthy fatty marrow, and when you go from cranial to caudal in the body, you get more fatty bone marrow. So it's physiological that in the lumbar spine there is more fatty marrow than in the thoracic spine, and in the pelvis there is even more. So it works best if there is lots of fatty background.
Marrow. Yes. Got it. So if a patient's anemic, perhaps, and they have a lot of hematopoietic marrow, may be a challenge to do that.
Yes.
Got it. Good. Now, the other thing that comes to mind, MRI for diagnosis of myeloma is pretty straightforward. There's a lot of contrast to noise ratio. The abnormal lesions are really bright in inversion recovery sequence. So that's clear, and that probably works pretty well on CT as well, just reading your technology and look at the images. But sometimes the myeloma has a more difficult pattern, maybe a salt and pepper pattern.
Yes.
How did you deal with that?
This was is one important limitation of our paper, that we had only patients that were normal and patients with focal lesions.
Okay.
And we completely missed patients with diffuse infiltration, for example. So this is really an important pattern that has to also be to be diagnosed.
Okay. And would that pattern be amenable to further technological refinement of the technique, or is that going to be a limitation of this method in general?
We kept on examining those patients, so now
Okay.
we have patients with
Okay.
diffuse infiltration or with combined diffuse and focal infiltration, and it also works. It's possible to detect it, and
Good.
yes.
So it's a matter of a learning curve and maybe getting the technology improvement as well. Is that right?
I think it's a learning curve for the examiner. So it's
Yeah.
it really, you have to look at some of those pictures. You really have to, in some cases, have the MRI to learn what it looks like.
I see. So having the MRI to guide you and interpret the images, because the images were the first time, essentially almost the first time done, and so it's hard to know what is normal and abnormal the first
Right.
time you do the study. Got it. Okay. So just to conclude then, what would be the next steps for the technique? Are you continuing to use it? More patients examined, or where's it going?
Yes, we are continuing to use it. We want to examine different patterns of myelomatous infiltration. So for MRI, the patterns are established, and for CT, it's only possible to detect lytic or non-lytic, to detect lytic lesions. So we want to try to establish maybe different CT patterns comparable to MRI patterns as well for dual energy.
Okay.
And I think an important point to look into is how treatment-related changes look in dual energy computed tomography.
Okay.
So if we get one patient in primary diagnosis and then look at therapeutic monitoring with dual energy, this will be certainly important for the future.
Good. And with CT, we always have that concern about radiation exposure. The dual energy technique, how's the radiation exposure going to compare to a standard CT acquisition?
Yes. So there are different papers out there, actually. Some of them tell us that in some cases the radiation exposure is higher. Some tell us that it's lower. For example, we did pulmonary embolism with dual energy CT, and we were able to lower the radiation exposure.
Okay.
So this is an important point to look into, and we'll certainly do it. But comparing to our previous generation scanners using dual energy CT, we are still below what we used to have at the, for example, 64 row scanner.
Okay, so that's encouraging. So your experience now, the radiation is under control.
Yes.
Maybe a little bit lower than earlier generations.
Yes.
Good to know. Okay, so any other final thoughts on the success of dual energy? You did a study on trauma. You did a study on tumors. Any other studies with bone marrow and bone with dual energy that you're thinking about?
We are continuing to do the multiple myeloma patients to look into the patterns and the trauma, the therapy-induced changes. So we'll certainly keep looking.
Excellent. Okay. Alexander, thank you very much.
Thank you very much.
Very nice paper.
Thank you.
Thank you.